As you know, BC is now in the 8th year of a drug toxicity public health emergency. Since 2016, more than 12,000 people have died in our province as a result of an unregulated toxic supply. Drug toxicity is now the leading cause of death in BC for those aged 10 to 59. And illicit drug toxicity is second only to cancers in terms of total potential years of life lost. As leaders of organizations with a mandate to support health and safety and reduce harms, we want to ensure that the public has access to the most current and accurate information we can provide on this crisis. We're here today to share what we know, be clear about what we're learning, and note where there are gaps to be filled. This public health crisis is significant and complex, and it's vitally important that all of those playing a role in responding share their experiences and the most up-to-date information they can provide. I want to acknowledge the many care providers and responders across the province who are working so hard every day to reduce harms and prevent deaths. As you know, BC's drug toxicity crisis is an illicit fentanyl crisis. Fentanyl that is illicitly manufactured and unregulated. We first detected this fentanyl in a very small number of illicit drug toxicity deaths in 2012. In the years since, fentanyl and fentanyl analogs have been implicated in the vast majority of deaths related to drugs in British Columbia. In 2016, illicit fentanyl was implicated in 67% of drug toxicity deaths. Since then, it has routinely been involved in more than 80% of deaths due to drug poisoning in BC. It was present in 86% of deaths attributed to unregulated substances in 2022. As updated monthly in our BC Coroner Service public reporting, other substances are also often detected. Cocaine and amphetamines and methamphetamines consistently since the start of this crisis, and more recently, benzodiazepines being present in a greater percentage of deaths than seen previously. Due to small detection percentages, we've reported on other opioids as one category. That includes heroin, codeine, oxycodone, morphine, hydromorphone, methadone, and others. Since 2016, the percentage of drug toxicity deaths involving these opioids has dropped, with one or more of these opioids being present in about 20% of deaths over the past 3 years. And I do want to reiterate that the vast majority of deaths that we investigate are mixed drug toxicity deaths involving a number of substances. With the introduction of safer supply prescribing, though still in limited numbers and in limited places in the province, there have been some questions asked recently about the role safer supply playing in the drug toxicity crisis. Also recently, there have been questions about xylazine. The BC Coroner Service, via the Provincial Toxicology Centre, continues to ensure that post-mortem toxicology testing is undertaken for any death where drug toxicity is suspected as a possible factor. To date, neither hydromorphone nor xylazine are present in any significant numbers. Fentanyl remains the main and most consistent and deadly driver of this public health emergency. You can be assured that we are closely monitoring continually for any and all trends that may impact public safety and will continue to report monthly. As you may be aware, the BC Coroner Service has held 2 death review panels into the drug toxicity crisis, reviewing in total the deaths of 7,861 people between January 2016 and July 2021. These panels were comprised of recognized subject matter experts from a variety of disciplines, all with knowledge and experience on the impacts and challenges of the drug toxicity crisis. Recommendations from these 2 death review panels, which can be viewed on the BC Coroner Service website, focused on the need for evidence-based outcomes, treatment standards, evaluation of outcomes, a comprehensive continuum of substance use care, and the assurance of a safer drug supply to those at risk of dying from the toxic, unregulated drug market. After hearing from 118 presenters and receiving 881 written submissions, the province's all-party Select Standing Committee on Health, reviewing the toxic drug crisis, made similar recommendations. Academic experts, experienced and knowledgeable clinicians, and those with lived and living experience have encouraged an expansive continuum of care. From harm reduction measures such as drug checking services, naloxone kits, and overdose prevention sites, to much more timely access to treatment services that are evidence-based and accountable, and to the provision of safer supply. It is estimated that more than 100,000 people in BC have an opioid use disorder. This number does not include British Columbians who use illicit opioids occasionally, or those who regularly or irregularly use stimulants, such as cocaine or methamphetamines. All of those tens of thousands of people are currently at risk of death or serious harm. A substantial, coordinated, comprehensive response is required. Something that has concerned me recently is the suggestion that Vancouver's downtown east side is the face of this drug toxicity crisis. There's no doubt that the people of the downtown east side community have suffered and continue to suffer serious harms in this unregulated drug toxicity crisis. But the downtown east side is not the face of this crisis. There were 323 drug toxicity-related deaths in that community in 2022. There were 2,340 deaths province-wide. The downtown east side comprised less than 14% of the deaths our province experienced last year. 86% of the deaths occurred in other communities, urban, rural, and suburban. The downtown east side is not the exemplar of this public health emergency. So who is the face of this crisis? Since 2016, there are 12,433 faces. 9,835 of them are men, 2,595 of them are women, and 163 were under the age of 19. The people behind these faces died in communities large and small, urban, suburban, and rural, and across all levels of income, education, and lifestyle. Most of them died indoors, most of them in their own residence. Those who died have left families, friends, colleagues, pets, and huge holes in their communities. They were loved and they are missed. The one thing they all had in common was using drugs from the unregulated, profit-driven, illicit drug market. More than 100,000 more people are at risk, and people are continuing to die at a rate of 6 people per day. As recommended by Death Review Panel experts and the Select Standing Committee on Health, a comprehensive response is necessary. This is not a dichotomy. Evidence must continue to be gathered, and facts must take precedence over partisanship. And now I'd like to call on the province's Provincial Health Officer, Dr. Bonnie Henry.
Thank you, and thank you very much for being here this afternoon. I as well would like to address some of the issues and concerns that have arisen and to share what we are doing in public health and in my world to monitor and address some of these issues. We know this toxic drug emergency is complex. There are many different facets to it, and there's no one single solution. We have innovated in many ways in this province, and we absolutely need to continue to do this. This crisis is affecting families and communities across BC, and you saw some of that, or you heard some of that from the data from the coroner's office. These are our brothers and sisters, our uncles, our parents, our children, our colleagues, our neighbors, and 1 in 5 people in British Columbia has been directly impacted by this crisis. And we all want the same thing. We all want our communities to be safe, to have a thriving environment, to care for all of our partners, our neighbors, our friends. We know that stigma and shame keep people from talking about their drug use or accessing services, especially health services. Decriminalization of people who use drugs is one way that we can address that stigma, particularly for that large group of people that we know aren't talking or afraid to talk to their family and friends about their drug use. So people feel safer reaching out without the threat of a criminal record, of losing their job, of losing their family. This is not legalizing drugs. It does not promote drug use, nor does it increase public drug use. We know the pandemic has made the situation much, much worse for many people across this province, especially people who are unhoused or street involved. The lack of shelter space, the increased substance use that we see in families across the board, whether it's alcohol or street drugs, anxiety and depression that have been a hallmark of this pandemic as it dragged on over this last 3 years. And we know the rapidly changing street drug supply made it much, much more toxic, particularly more recently with the introduction of benzodiazepines in a large proportion of the. And now, of course, we see this compounded by inflation and challenges with housing and poverty. We know as well that First Nations, Métis, and Inuit people in this province are more negatively affected, and Dr. Louie will be talking about that directly. This has also led to increased visibility of some people who are homeless, people who have mental health and substance use issues. Decriminalization of people who use drugs is new, and we must and are monitoring carefully for risks or harms as well as benefits of this. We have an independent provincial monitoring plan, and the BC CDC and our public safety partners are monitoring as well. It has been a very short period of time since this policy came into place, but we have not seen changes at a population level in our surveillance data across the board. The indicators that we have show that we've not seen an increase in, for example, changes in visits to overdose prevention sites. We've not seen a change in concentration of fentanyl or other analogs in street drugs. We've seen an increased demand that has continued for many years on take-home naloxone kits, and perhaps it's because more people are feeling safe to go and access them. We have been hearing concerns, of course, about child drug poisonings, and we've added this to our indicators as well. And I can say we have not seen an increase in paramedic-attended opioid overdose events in children. They are, thankfully, very rare. There's less than 10 per year, and that includes both legal and illegal drugs. And we have not seen a change in that since 2018. We will and we must continue to monitor and address concerns about public drug use. It has always been an issue, and we must work together to find some solutions, but solutions that don't involve recriminalizing of people who are the most vulnerable, people who are unhoused, people who are living in poverty. As well, during the worsening situation during the pandemic, we introduced what were called risk mitigation guidelines to support people who were addicted or who had opioid use disorder or who were using drugs if they needed to isolate, if they were sick with COVID. And we've also used these to support people who've been evacuated, for example, during the wildfires. With anything new and innovative, we must have robust, independent evaluation, and we have that. The risk mitigation guidelines that came out in 2020 allow for doctors and nurse practitioners to prescribe a range of medications, pharmaceutical alternatives to the toxic street drugs. It's been colloquially called safer supply. Except for very limited places and clinics, mostly in urban areas in Vancouver, this meant prescribed hydromorphone, or Dilaudid, as it's commonly known. This hydromorphone prescription was an intervention designed for a very specific purpose during a time of dual public health emergencies where we had the pandemic and we had issues with people being able to access medications and drugs, as well as needing to isolate, and we had the increased toxicity of the crisis that we were dealing with before the pandemic. The landscape has changed very significantly since this started in 2020. And as we emerge from the emergency phase of the pandemic, it is time now to reevaluate and adapt to what we are seeing now. Our understanding of the many issues and needs has become more refined, though the urgency is greater than ever. We are hearing from clinicians that this prescribing, particularly of hydromorphone, is not meeting many people's needs, and they are hearing concerning stories, which we've heard as well. We know the drug supply has changed dramatically and rapidly over the last few years as well, and we need to continue to look at the data. Since March of 2020, our data show that stimulant use is increasing in people who have overdosed on toxic drugs, that more people are smoking than ever before and seen as less risky than injecting. As many as 40% of samples now tested contain some benzodiazepines as well, which makes it much more complex when people have an overdose or when people are trying to get off drugs. Really importantly, we have seen no increase in new diagnoses of opioid use disorder. So this is something that we have been following for some time across all age groups. In most age groups, it has actually decreased. We've also seen no change in the number of people with only hydromorphone drug toxicity deaths. Sadly, this has been an issue for many years, and it remains a small but proportion of people who only have hydromorphone. If we look at specifically at opioid use disorder in young people, in those aged 19 to 24, there has been a decrease in new diagnoses since 2017, and thankfully in youth under 19, it has been stable and low since 2017. We need to really pay attention to this. It's never been zero. There has always been some access of young people, and that's something that we need to take seriously and we need to work at. But it's important to know that at this population level, there has been no change in either since the Safer Supply program started in 2020. I will say that all of our data have limitations. They are not perfect. We know there are challenges in accessing primary care and getting a diagnosis, but it is important to see that these trends over time are not changing, and we will continue to monitor these. It's also important that we have independent evaluation from people who aren't wedded to the program working or wedded to the program failing. And early evidence from these evaluations show there is some benefit, at least in certain populations, of these medications. It reduces the risk of death due to toxic drugs, improves engagement and retention in healthcare, including addiction treatment, and improve people's overall physical, mental health, and well-being. But we are also hearing from clinicians on the front lines that they have increasing concerns, particularly about some patients and prescribed hydromorphone, and with the change in drug supply. So the program needs to be reviewed, given the situation that we are in right now. We are also hearing from people who use drugs that access and barriers remain their biggest challenge. Less than 5% of the people who use drugs that we know about have had access to prescribed Safer Supply, and it's very geographically focused. That is important too, and we need to adapt and review policy and guidelines with the best possible evidence that we can collect, that are supported by our evolving experience, both from clinicians and from people who use drugs, and endorsed by all of the stakeholders. There is no doubt new innovation and new innovative measures will need to be adapted as we learn and as we develop our evidence. This is expected and needed. And I will be working together with the addiction medicine specialists in this province, with clinicians, the Ministry of Mental Health and Addictions, our public health teams, people with lived and living experience, to adopt and revise the policy and the clinical guidance to incorporate this emerging evidence as we are now in a new position. I want to emphasize that this is one important tool, but it is one of many that are needed to address the crisis we are in. We also need access to treatment and recovery when people are at that point where this is something that is possible for them. We need to continue to have an increased access to overdose prevention services and safe consumption services so people do have a safe place to go. That makes our communities safer too. We need to increase our drug checking and other harm reduction tools. We also need to ensure that we are doing what we need to do around prevention of use of drugs in the first place, particularly for children and youth, and enforcement, particularly with a focus on organized crime. These are not in competition with treatment or abstinence. We must also acknowledge housing and poverty are major drivers of this crisis, and those are things we need to work as a community together to address, particularly for First Nations, Métis, and Inuit peoples in this province through intergenerational trauma and racism that still persists. Every response to this crisis requires careful evaluation and monitoring, including treatment and recovery services, safer supply or prescribed pharmaceutical alternatives, and other innovations designed to save lives. Evidence is being generated with these new and innovative programs, and adjustments will be necessary, and we are committed to doing just that. I will now like to introduce Dr. Kelsey Louie, who's the Deputy Chief Medical Officer for the First Nations Health Authority.
Thank you, Dr. Henry. Imut tat kwananape. It's good to see you all. Benalsaltin asnan hes kwslamantua, acknowledging my traditional name and the territory where I come from. Chechahathech kwa Laquangan kaimuch asna ta gije. Just acknowledging the traditional lands on which we are gathered here today from the Laquangan people's territory here in the beautiful Victoria area. I'm honored to join my esteemed colleagues to provide some remarks on behalf of the First Nations Health Authority. It is well understood that the historical and current realities for First Nations people in BC are complex and varied, including but not limited to the effects of intergenerational trauma due to colonialism, systemic racism, and ongoing environmental and climate-related emergencies. We also know that there are First Nations people who have died from overdoses while coping with physical medical conditions, who are using drugs recreationally, and even those who are experimenting. Given the complexity of the underlying issues that impact BC First Nations, and that the issues are unique to the lived experience of every individual, it should come as no surprise that the solutions to the problems are equally complex. There's not just one approach, but many. While much discussion surrounding drug use and its various outcomes appears to focus on inner-city residents, and in particular the downtown east side of Vancouver, we must acknowledge that this crisis affects both urban and rural communities across our province. While one model or program may not be effective in an urban setting, it could have life-altering possibilities in remote or rural communities. There are those voices who would attempt to simplify the issue, and in doing so, often conflate other societal concerns, such as street crime, homelessness, or mental health issues, with unregulated drug use. While these issues may sometimes be codependent, it is important to note that this is not always the case. There are many factors influencing the rates of crime and violence in our society. From a First Nations perspective, we continue to engage with our local communities, both urban and rural, to develop culturally safe health and wellness programs that meet the unique needs of the community and those most impacted by toxic drugs. While we have made some headway, there is still much more work to do. While our approaches look different across the province to meet the unique needs of our communities, our foundation is always the same, focusing on culture, traditions, and land as medicine to bring our teachings into our healing journeys. Acknowledging the grief and loss from all the lives lost that perpetuate the trauma and pain. Providing opportunities to bring programs and supports closer to home so people do not need to leave to get the help they need. Working to improve access to withdrawal management programs and treatment options across the province so we can support people when they are ready. And listening to the voices of people who use drugs to develop opportunities that meet their needs in a way that they need it. There is no magic bullet, no one-stop shop or quick solution to ending the drug crisis. One only has to look outside our province to other jurisdictions in Canada and the US that are also struggling to stem the tide of unregulated toxic drugs and the subsequent harms from drug use. Given that lives are at stake, this is not a time for division, but for people from all walks of life and political persuasions to come together with a common purpose, to find creative solutions to a problem that affects us all in some way, and especially those who use drugs, their friends, their families, and their coworkers. We continue to work with our partners to determine the trends and impacts on First Nations people to try and understand the complexities and diversity of response approaches across the province. Our experience over the past 7 years, since the declaration of a province-wide state of emergency on toxic drugs, consistently reveals that First Nations people continue to be overrepresented in the harms and fatal consequences of unregulated toxic drug poisonings. The other truth is that this is not the same emergency as it was in 2016. The supply is more potent, more unpredictable, more dangerous, and potentially more deadly. Now, it is not just opioids that we are worried about, but also the other contaminants that make resuscitation from a poisoning event even more challenging. Now is the time for a risk management approach that pushes the limitations of our systems and is now our opportunity to do things differently. To find unique solutions to these complex issues, to listen to our knowledge keepers and experts in this work, and to trust that we are working to reduce harms which can look different than the work we do to address the root causes of addiction. Regardless of the challenging work ahead, we must remain hopeful and positive. We must seek to find common ground with those who may disagree with the approaches and perceived outcomes. We must continue to do this work because it is in our best interest and that of society in general to find ways to work together to reduce the impacts of unregulated toxic drugs on our people. The health and wellness of our people depends on it. Now I'd like to introduce Dr. Jennifer Charlesworth, BC's representative for children and youth.
Thank you, Dr. Louie. Good afternoon, everyone. I'm pleased to be here today on the beautiful lands of the Lekwungen peoples to speak in support of my colleagues and also in support of broad, reasoned, and evidence-informed approach to address the toxic drug crisis that is touching so many families in British Columbia. As you've already heard, this is an extremely complex issue and there's no one simple solution. If there was, we would have done it. As BC's representative for children and youth, one of the roles of my office is to analyze the injury and death reports we receive regarding young people who are receiving various services from the provincial government. Sadly, we see the devastating impacts of the toxic drug crisis every single day in the reports that we receive of the injury and deaths, but also through the individual advocacy casework, helping parents and their children who are too often struggling to get the help and services and supports that they need. As RCY's current social media campaign reminds us, the toxic drug crisis that has hit this province over the last 7+ years doesn't just affect adults. It is harming kids too. In 2022, 34 British Columbians under the age of 19 died from toxic drug poisoning. That's a 160% increase since the pandemic or the public health emergency was declared. But the impact is much larger than that. In 2022, 327 people in BC between the ages of 19 and 29, which stretches our understanding of youth, died from overdoses. Of the 133 child and youth deaths reported to my office in 2022, 18 were from suspected toxic drug poisoning. In the same year, we had 166 critical injuries reported to us related to toxic drug overdoses of children and youth. And these injuries, while not resulting in death, do impact health, sometimes resulting in significant brain injury, always adding to trauma. But the impact doesn't stop there. In 2022, 145 children that became known to us experienced an emotional harm injury due to the loss of one parent, sibling, or a significant caregiver in their lives to the toxic drug crisis. And all of this is occurring while public services in BC for children and youth who use substances and their families remain inadequate, despite considerable efforts and investments. As I said, we see the effects of the toxic drug crisis in our work every single day. But I want to be clear about what we aren't seeing. We aren't seeing any indication in our data and the stories we track that youth are using from diverted safe supply. The injuries and deaths reported to our office are coming as a result of youth accessing the illicit supply, and these youth are typically using an array of substances. They are also often dealing with other challenges to their well-being, especially mental health concerns and unbelonging. Might this observation with respect to diverted safe supply change? Is it possible that diversion will be an issue in the future? Anything is possible within this highly complex and fast-evolving crisis we are all in. However, we're working with our colleagues in the BC Coroner's Service, the Provincial Health Office, health authorities and ministries, as this is an all-hands-on-deck call to action. Through sharing information on shifting trends and patterns, whether that be geographic, demographic, types of substances being used, how they're being accessed, access points for services, services being requested and needed, or wait lists, we can continually update our knowledge and plan accordingly when we work together. Through our advocacy work and in-depth reviews, young people are advising us that they are accessing the illicit supply in order to cope with the trauma that they are dealing with in their lives. In 2018, my office did an in-depth report entitled Time to Listen, which offered the first-hand perspectives of 100 young people in BC with lived experience of substance use, and also drew upon lessons learned from RCY aggregate reviews of substance-related injuries and deaths. Certainly, the landscape has changed considerably since 2018, and not for the better when it comes to this issue. The illicit drug supply is poisoned more than ever and is constantly changing. Still, the overarching recommendation from that report remains valid. It called on government to develop a comprehensive system of substance use services capable of addressing the diverse needs of young people. And that is still what is required today. A comprehensive system of voluntary services and supports for young people who are dealing with something much different and much more complex than many of us had to navigate when we were young. This array includes harm reduction, education and prevention initiatives, family supports, all the way to residential treatment. Safe supply is a key to that system. For those young people using substances to numb their emotional pain, we must do whatever we can to keep them alive until they are ready to move on to treatment. Safe supply is an alternative to the poison that is available on the street, and I'll repeat for emphasis what I said earlier. There's no indication from our data that diverted safe supply is causing overdoses for children and youth. As has been mentioned by my colleagues, what we're seeing is an array of substances and that young people are using. It's a very scary time, and some days it feels overwhelming, particularly for families, first responders, and health and social care professionals. Young people are struggling, and the illicit supply is so poisoned that the risks of use, whether through experimentation, occasional or regular use, are extraordinarily high. Different perspectives are invaluable in the face of this complex foe, but this is no time for polarizing, fear-driven, and often political conflicts. We need to hold the tensions, work together, and be willing to try evidence-informed actions in an effort to outsmart the manufacturers, dealers, and organized crime that are truly hurting our young people. I will continue to be informed and respond accordingly to the data, research, and the voices of young people, and work with my colleagues across the board that are trying to effect change in a very, very complex issue. Thank you, and I'll now turn it back to Ryan.
Thank you, Jennifer. A reminder to anyone joining us on the phone today hoping to ask a question to please press *1 to enter the queue and to please identify the speaker or speakers you would like to respond to your question. But we'll start in the room with Richard Zussman, Global News.
I think this is for Dr. Henry. It could also be for Lisa Lapointe. when these drugs are diverted, the product gets moved around and money then gets exchanged for the purchase of other drugs. How can the province put safeguards in place to prevent that from happening? Is there any concern that the prescribed drugs are being used as a commodity to get access to other more deadly products?
Thank you, Richard. Do you want to respond? I think one of the challenges right now is that we are dealing with a lot of anecdotal information and allegations. Of course, we know that while this is a serious health issue and it requires a health-focused response, drug trafficking remains a crime. And if there's evidence of drug trafficking, then law enforcement is responsible for doing what they can to change that trajectory. We, as a coroner service, can certainly access PharmaNet records, so we would know if a person's dying of their own safe supply. In terms of testing, postmortem testing, we continue to do a broad spectrum of postmortem testing whenever we think drugs may be involved in a death, and report on everything we find. We continue to report on hydromorphone. We've not seen an increase in hydromorphone in post-mortem testing. That doesn't mean that some of that diversion isn't happening, but it is certainly being monitored. And as Dr. Henry commented, opioid use disorder has not been increasing. I think there's some of us have talked about if there was more safer supply out there, would that reduce people's reliance on the illicit drug market? Is that a bad thing? I'll leave that's another discussion for another day.
I think there's many different levels to that, obviously. And it's prescribed hydromorphone that we're seeing as a big issue being raised, and the anecdotes, the stories that we're hearing around particularly specific clinics. And so there's a whole number of things. One is we know that hydromorphone has been on the street for a long time, and the vast majority of prescribed hydromorphone is prescribed to people for pain or for other reasons. A very small percentage, so we can't, what's the right way to say, we can't blame it on safer supply because that has been very limited. Very small percentage of the hydromorphone that's prescribed is under that program. And yes, it probably isn't. Well, we hear from clinicians that it's not meeting the needs for some of their the clients and the patients in their clinics. And so it is possible it could be used for people to get other drugs that are meeting their needs. What we're also hearing from people who use drugs is that sometimes they use it as a commodity for friends, for others who don't have access, that they sometimes will save their supply so that if they're in a place where they don't have access to drugs for whatever reason, they have something that they can use to help support them through withdrawal symptoms. So there's a whole complexity to it that is very challenging to figure out. We know that particularly hydromorphone pills are not meeting the needs in a broad variety of places, but they are working very well for a number of different populations, for example. So it's a complex thing. We are looking at it. We're working with clinicians. We need to revise our guidelines and look at what are the other things that people need to support them in getting off the toxic street drug supply. And it's on that continuum of care, from treatment to, in some cases, abstinence at the end of that continuum. The other thing we're hearing, and I know the coroner has been talking to some of our public safety friends, it's very difficult to determine whether something is from a prescribed safe supply or another prescription from other sources. We also know that drug dealers will use that as a selling point, and that there are fake dilaudits out there, and that nobody is safe from those either. And it's very difficult to tell the difference between fake manufactured or prescription hydromorphone. So that's a challenging thing for people on the front lines dealing with that. We're not seeing it making a substantial difference to the amount of Dilaudid that's out there in the community, or in seizures that police are reporting on. Will it happen? Is it happening? We hear stories. Absolutely. It seems to be happening for some people. But that doesn't mean we throw out the whole program. That means we need to see what does meet people's needs. How do we make sure that it is the right medication for the right person? And how do we work on that given what we know now about what we are seeing in the street drug supply?
As part of that review you mentioned earlier, I think you alluded to at the end, and to tie in the comments that the chief coroner made at the end, does that mean we need to consider broadening the types of drugs that are available through prescription, or is it just about mending the amount of the hydromorphone? Or is the conversation much larger than that, that if the drugs aren't the ones people need, maybe more drugs need to be made available, which politically could become a challenge as we're seeing with this issue as well, I'm sure.
It's all of the above. And I've been working with clinicians. We've had a number of meetings over the last few weeks. As the situation has changed, particularly in the last month or so, we've been trying to assess what is it that we need to do. We're now getting, as I mentioned, some of the early data. Much more of it is going to be coming available. We're still early days in this in many ways. So we're looking at, over the next few weeks, what do we need in the program? What does a program look like? Who should be prescribing it? How can we do it in a way that reduces the barriers to access, which are also what we're hearing are big challenges for many people, especially geographically around the province. How do we best support rural communities, remote communities? So we have everything on the table right now, and we're committed to working with stakeholders, from our clinicians to people with lived experience, public safety colleagues, to try and get the best that we can, to take the best from what we've learned, where the evidence points, and develop it from there. So it could include, I absolutely think it needs to include additional medications being available, different models for how people can access those medications, and continuing surveillance and monitoring so we can tell if things are working or not.
Okay, now we'll go to the phones. Our first question from the phones today is from Francis Plourde, CBC.
Yes, just a question for Dr. Henry. Dr. Henry, you mentioned, that you would be working with specialists to adopt and revise policy with the emerging evidence. Can you give us a sense of, how it's going to be revised, and what are the concerns coming from physicians?
Yeah, so we've talked about quite a lot of them. So there are emerging evidence in how to manage opioid use disorder. That is from global information, from information that's coming out of the programs here in BC and across Canada, and from the complexity of what we're seeing in the street now. And I mentioned the use of stimulants has gone up quite dramatically here. And as we know, many people use multiple substances, but the adulteration of street drugs with benzodiazepines makes things much more complex. So all of those have to be factored in, and the clinicians from the BC Centre on Substance Use and the addiction medicine physicians across this province are committed to helping us develop the best possible guidelines. We also have emerging evidence on some of the benefits, that early evidence on benefits that being involved in these programs have for people who do have access. So we need to take that into account as well. And we need to look at new models. Is it a physician, nurse practitioner prescribing an individual medication for a physician or for a patient or a person, the best model? It's very difficult to scale that up. It puts a lot of pressure on clinicians. So we need to look at those as well. And my office is working on that, looking at the data, looking at what other models could be out there to support people having access.
Francis, do you have a follow-up?
Yes. A recent poll was by Research Co. was showing that there was dissatisfaction with the way the crisis was handled, and I'm wondering now, it's been more than 7 years since we're in a state of emergency. The situation doesn't seem to be improving, and there's been several experiments, but the results haven't shown yet. So I was wondering what was the message that you would send to people who are getting impatient in face of a lack of, I guess, significant turn or change with the overdose crisis.
You know, I think we all need to look back. The world has not been static in those 7 years, and there are many other factors that have played into the success or not of many different parts of this. And I can't overemphasize the fact that this pandemic made things dramatically worse. We were seeing some encouraging, positive rates of decline in deaths and access to services, and some movement that was actually going in the right direction in 2019. When the pandemic hit all of us around the globe, it changed things quite dramatically, and we have seen a worsening. And there are multiple different factors to that, including, things like inflation and access to services, in the services that we have in a very stretched healthcare system. The drugs themselves have changed dramatically over the last few years, and where they come from and how they're manufactured, and the toxicity has changed very rapidly. And we have not been able to keep up many of our programs from a health perspective. We're stretched in our healthcare system. People were isolated. We saw an increase, particularly, and the coroner talked about this, about the young men in the 30 to 59-year age group who are living at home. That proportion of people increased dramatically over the period of the pandemic. So how do we address that concern? And that's a place where, prescribed hydromorphone may be an appropriate medication for many of those people, where decriminalization of people who use drugs gives them a way to safely talk about their drug use with family and friends who may help. So there are many, many different factors here, and there's many factors that are influencing what we're seeing in terms of public safety and people. So there's no simple answer to this, except that we need to have hope, and my colleagues talked about this. This is a crisis that is affecting our families, and that very same study showed that 1 in 5 people in this province have been directly affected by this crisis. So it's not we can't abandon things now. This is a time for us to pull together. We have learned a lot through this last little while, particularly through the experiments of these last 3 years. And we need to put that together. We need to put all of our best minds together to see how we move forward to protect people and to protect our communities.
Our next question today comes from Zhao Zhu, Globe and Mail.
Thanks. This is for Dr. Harry. Could you please say when this review of the Safer Supply Program will take place, when you might have results, and what kind of street drugs would you like to see safer supply of?
Yeah, so I don't have exact dates for you. The process has started. We've been working with the BCCSU, been meeting with clinicians who are on the front lines of this, meeting with people at the BCCDC. We've been looking at this data as these concerns have been brought up by clinicians in different parts of the province. So it will be over the next few weeks to months, however long it takes us. We'll be reviewing, we have some updated opioid use disorder clinical guidance that is in the final stages. There's policy work that we need to do. So these are things that will take some time. And I think there's a variety of different things. We know that there are a variety of different opioids that would be of benefit for people. And we have some limited data of people using powdered fentanyl to support people getting off the toxic street drugs that they would otherwise access. That has been promising. It's the prescribed hydromorphone that has been most of the issue right now. So are there alternatives? Where is that a good medication to be used? The other medications, of course, are diacetylmorphine. Still some very great challenges globally in accessing diacetylmorphine. We also know that, as I mentioned, there's increased stimulant use, And that is a very different game and very tricky game. So how do we look at what can we do to support people, particularly people who are detoxing, for example, on opioids and stimulants? What do we need to do to make sure that that stimulants are increasingly seen are being contaminated or cross-contaminated with opioids, and that is leading to tragic outcomes as well. So there are many, many different factors here, and it's going to take as long as it takes for us to do the best that we can, and then it will be an iterative process. There is no one single thing that's going to, it's not going to be, okay, this is the policy now and change. It's going to be adapted as we learn more and as more of the evidence becomes available.
Zhao, do you have a follow-up?
Yes, I do. This is for Ms. Lapointe and maybe Dr. Henry as well. You've been referring to people dying as a result of an unregulated drug supply. How should a regulated supply be distributed? Through prescriptions, or should, as some medical advocates have suggested, the safer drugs be available in the same way governments regulate alcohol and cigarettes with no need of a prescription?
Yeah, so part of our challenge is many, many decades of prohibition is what has led to the toxic street drug supply that's out there. So yes, the Council of Medical Officers of Health, or the Health Officers Council here in BC, came out with a paper a number of years ago talking about the public health approach to psychoactive substances. And we know that when it's unregulated and there's nothing, that it's very highly toxic and that harms can be very great. We also know, and we see this with alcohol, that if we promote its use, we also see a lot of harms. So we need a spot somewhere in the middle. And I would say that the experiment, or what we're doing with legalization and regulation of cannabis, fits into that. Where you have enough controls and you have enough regulation, but you also have a monitoring and safety of the product. So in the long term, would that be a way to counter the toxic street drugs and to take that business away from organized crime? Absolutely. But we're not there yet. Where we are right now is looking at how do we manage with what we're faced with right now, which is an increasingly toxic drug supply that a small number of people are making a lot of profit on, and a lot of people are experiencing harms. So measures like decriminalization of people who use drugs, that give them the wherewithal to be able to reach out to people and to talk about it, and having access to pharmaceutical alternatives to support people until they are, if they ever, to stabilize their lives, to save their lives. And at some point, for many people, that means moving on to treatment and recovery. You want to add to that?
Our next question today is from Melanie Nagy, CTV.
Hi there. Thanks for taking my question. We haven't had all of you together for a press conference in a while, and usually when we do, it's the anniversary of the declaration of public emergency or a significant jump in loss of life. To have you all today was really interesting to me, and it kind of comes as we're hearing more and more from advocates and academics that harm reduction, particularly safe supply, is becoming overly politicized. And we've seen this from a provincial level, a federal level, hammering away at safe supply. And I'm just wondering if how much of today is you standing in a united front against that, and how much you're worried about this conversation now becoming what seems to be politicized and rooted in emotion rather than evidence.
Yeah, I think I can speak for myself, and this is something that we've been talking about for some time, and I have been very concerned about the polarization and the conflating of people's tragedies with public safety issues, or with safer supply being a cause of something. So those are very important considerations, because we know it's not that simplistic. And it appeals to people's emotions, but it also causes harms. for people who are the most visible. So people who are unhoused, who are living on the streets, we know that this type of discourse makes people afraid and marginalize more and causes more stigma and causes more adverse reactions to people, where we all want the same thing. And I started that saying that we all want to live in a community that supports people, where we have supports that people need when they need it, that we recognize that these things happen to young people. Experiment, sometimes they become addicted to alcohol, to drugs, and we need to have a system that supports them in doing that and in getting over that in a safe way. I'm not being very articulate, but yes, it's very concerning. I want people to know, and we want the public to know, that we don't take these things lightly, that when we hear concerning stories and reports from our clinician colleagues, from media, from reports that people tell us, our friends, that we do investigate them, that we are not just doing this without having robust monitoring and evaluation in place. We know that our data is not perfect, but we are following it and have been following it over time in the best ways that we can. And we want people to know that we are still following these things, that we're not seeing some of these dramatic stories that are out there. We're in the data that we are seeing. We can't make our policy and change things based on individual stories or anecdotes. We need to have the data behind it, and we need to take seriously the reports that we're hearing from people with lived and living experience, from clinicians, and from public safety, from the medical, from public health. And all of us agree that we need to put this evidence together as it's emerging to create a more comprehensive picture so that we all understand what is happening and what's not happening, and what are the things that we can do together to try and improve things for all of us in our communities right now. So I am very concerned about the dialogue and the polarization and the emotion that's put in there, because what we don't want to do is to have that lead to throwing out the good things along with the things that need to be adjusted and changed and reviewed or stopped. Anybody else want to talk to?
Thank you, Bonnie, and thank you for the question as well. So I will just add a piece as the representative for children and youth that builds on what Dr. Henry has already said, is when public policy is being driven by fear, by polarized opinion, by anecdotes, it actually causes harm. And so when I think of our young people, it takes us away from understanding what's giving rise to young people using substances in the first place, which, as I've said, young people are telling us that they are often using to numb emotional pain. They have experienced trauma, be it intergenerational, historical, or cumulative trauma based on what they're experiencing in life. The pandemic has not been kind to our young people. So it is important that we collectively work together to say, please, please, please don't believe everything that's written and come back to taking a look at what does the data tell us, what do young people or people with lived experience tell us, what do the clinicians tell us, and let's weave that together in such a way that we're actually making sound public policy. And I have to say too that the manufacturers, the dealers in organized crime are extremely sophisticated entrepreneurs, and they iterate very fast. So we have to be just as smart and just as bold and just as robust in our response in order to make sure that we change the trajectory of the harms that are being caused, particularly to our young people who I'm most concerned about. So yes, we are standing together saying fear-based, polarizing rhetoric that is not evidence-informed is causing harm. Thank you.
Melanie, do you have a follow-up?
No, that was excellent. Thank you.
Okay. Our next question today is from Brenna Owen, Canadian Press.
Thank you. Yeah, I am kind of echoing the previous question. I think a lot of what has been said today appears to be countering messaging from the federal conservative leader, Pierre Poilievre. So, I think you have spoken a little bit to this with the previous question. I just want to put it even more directly. Why was it important, and what prompted the four of you to come together and speak out today, since it seems like it was directed at Poilievre's messaging?
Thank you for that question. We didn't prepare today's gathering in response to any one person or any one media report, but as my colleagues, Dr. Henry and Dr. Charlesworth, have said, we have been concerned, and of course we do speak regularly. We are focused on saving lives. We are focused on reducing harms. We have seen far too many harms and far too many lives lost and far too much suffering in our communities. And we have been concerned about this increasingly polarized rhetoric that is not informed by evidence, that is not paying attention to evidence, as a matter of fact, and is sharing opinion or anecdote that in fact is clearly not defensible if you look at the data. And so we thought it was really important that we come together and assure the public, as Dr. Henry mentioned and Dr. Charlesworth, that we are looking all of the time for any trends or risks to the public. But when we see people objectifying populations, setting the downtown east side as an exemplar of everything that's wrong in our province, that disturbs us. That is a community of people, some of whom are facing significant challenges, but they are a community. That is a very strong community. And we want to support people. The other thing that has been concerning is some of the rhetoric around, and we completely understand, certainly my office has spoken about this a lot in the last few weeks, concerns about public drug consumption. Some of the language that has been used and some of the characterizations of people who use drugs, it's just wrong. We know the people who use drugs. They're the over 12,000 faces across this province. And that language and that rhetoric and that divisive tone, it just drives people further underground. It drives your children, if they're using drugs, they will not come forward, or your relatives or your neighbors, and that is the most harmful thing we can do. So we really, really want to help people understand that there is data. We are constantly monitoring the data where there are risks to the public. We have been loud and clear over the last several years where we've seen risks, and the divisive tone worries us greatly, and we're very hopeful that we can encourage people to move away from that divisive tone. Anytime we've brought together a panel of experts, including the Select Standing Committee of the Legislature, the recommendation has been for a comprehensive approach across the spectrum of supports for people. This is not, as everybody has said here, not an either or. This is an and. We have tens of thousands of people at risk of dying. We've seen more than 12,000 deaths already since this emergency was declared. So we need to be brave, and I've said this before, we need to be brave about having this suite of supports and services available to meet people where they are and reduce the harms and the suffering.
Brenna, do you have a follow-up?
Thank you very much for that answer. Yes, I do. We've heard Poilievre use language like, drugs are flooding the streets under drug policies and programs. So I am wondering, we've talked about the data not showing particular signals right now, but what's maybe just, you could expand on what's being done to investigate potential illegal use of prescriptions that are being acquired through the Safe Supply program. I'm thinking maybe Dr. Henry, I think I heard you mention particular clinics. Just, we've talked about the data, just wondering if you could talk about the kind of investigative approach.
Thank you, and I will turn this over to Dr. Henry for reply.
Well, yeah, a challenging thing, and not the investigation of that on an individual basis is not what I do. Obviously, clinicians have one-on-one relationships with their patients, with people who are accessing these drugs, and they are telling me in some cases they've heard stories that people are doing this. So that's important. That is concerning to us. That means we need to look at the program as a whole and see what is it that is meeting people's needs or not meeting people's needs. But if we, in terms of flooding the street, as I've mentioned, things like hydromorphone, OxyContin, other prescription medications have been available on the street in large numbers for a long time. The amount that is being prescribed in the limited program that we have here in BC is a very small percentage of what has been out there from drug seizures we know, from talking to people who use drugs, so it cannot, even if all of the hydromorphone that was prescribed in the limited prescribed safe supply program that we have made its way to the street, it would be a very, very tiny percentage of what is out there. And that's the challenge that we're facing. There is a lot of availability of drugs in some parts of this province, and in many parts of the province you can get it access delivered to your home. So those are challenges that our public safety colleagues are faced with and that we're working with them with. But we are not hearing from them that the prescribed program has made any significant change in that circumstance on the streets.
Our next question is from Michelle Gamgee, the Kai.
Hi there. Yeah, this question is for either Dr. Henry or Charlesworth. I'm curious to hear from both of you why you think we're hearing all this narrative about children and about the harms perpetrated against children by Safer Supply, and the child-related deaths, if we're not actually seeing these numbers. Like, where does that narrative come from?
Well, I think these are very important stories, and we're hearing stories of individual children who are affected. I don't know the details of those tragic deaths, but I will say that sadly these are not new stories. They are not linked in time to the Safer Supply program, although that's what some would have you believe. So I think we need to pay attention to these stories. They're an indication of what's happening out there. And as Dr. Charlesworth was talking about, this has been a very difficult 3 years. We know that anxiety and depression, especially in youth, has gone up dramatically. And for some, that means reaching out and using drugs to help numb that pain, to help people cope. And for some people, using drugs, even a limited amount, leads to dependence and challenges. So these are important stories. They're not new stories, sadly, but they are ones we need to pay attention to.
Thank you very much for the question. And in the work that we do, obviously, we are taking a look at reports, but we're also walking alongside children and youth. We come to know them and their stories, and we come to know the stories from many family members. And I've spent considerable time in my tenure speaking with families who are trying to make sense. And I think what we're seeing is, and with this rise is, and I have to bring tremendous amount of compassion, when something feels out of control, and when a family is struggling so deeply to make sense of things that are so catastrophic, so painful, they look for the definitive answer. That's just a human thing. We're all looking for the simple solutions or the definitive answers. If not for this, then this bad thing wouldn't have happened. And sadly, there aren't any definitive answers. What we're seeing is a pain problem, emotional pain, physical pain, psychological pain, and children are turning to substances as part of their coping mechanisms. And I think it's important that when we take a look at this, we recognize that it's always been present. Substance use has always been present, generation after generation. What we're dealing with now is a poison supply that has very, very serious repercussions. But I think what's arising is that sense of this is scary, this is uncontrollable, and trying to find those simple solutions. And I understand where people and families are going to with their trying to make sense of what's going on. But let's go back to the data. Our children are in pain. They're often dealing with multiple things, including mental health. They might have experienced sexual violence. It's significant. In our communities, they might be experiencing exclusion from school. COVID pandemic has had a tremendous impact on mental health. And so that combination of things, plus the stressors that many families are experiencing right now, that's what's contributing to young people using substances. So we have to be much more open to taking a look at a more systemic response. Hopefully that's helpful. But we can't find, there is no definitive answer, but I understand people's desire to try and find the culprit.
Michelle, do you have a follow-up?
No, I don't. Thank you.
Okay, then our final question today comes from Kier Junos, City News.
Hello, this is a question for Dr. Henry. Perhaps you can describe some of the models the province is considering when it comes to expanding limited safe supply as it stands now. Maybe you could describe it in a way that sort of, describes like the paradigm for access to safe supply now and what's looking realistic, what's looking possible for the province in the future, in your view.
Yeah, so this is something we're working on, and we've been looking internationally around models that work in other countries, how they might be adapted to the situation that we have here. So from my perspective, there's no one model, one way that I would recommend at this point, but we are looking at the spectrum of how people could, in a safe way, access supplies with controls. And I think that's really important. So right now we have very limited prescriber model where physicians and nurse practitioners have to have an individual prescription for somebody. So we can look at a spectrum from having a health authority program, for example, where people are able to access. We hear from people that some of the challenges are how you access the healthcare system, and we heard particularly from First Nations, Métis and Inuit people that it's not always safe to access a medical model. So are there non-medical models that still have controls? So it's not just drugs being available to people whatever they want, whenever they want. But what we need to have is controls that meet people's needs with different medications being available and different types of models that make it scalable, make it accessible for people in smaller remote communities where they may not have access to medical services or clinics in the same way. So there is a lot of work going on that right now. There is no definitive model that I would say right now that we need to that we need to move to. But we are continuing to look at that and to consult about how, and to, I mentioned that there's a lot of evaluations going on right now, and some of that evidence is coming out. So we need to get together, and we'll be doing that over the next little while with some of our research colleagues here and across the country to say, what does it tell us? Where are the gaps still? What can we do to fill in those gaps so we know more about what is working and what isn't working? So that's what we'll be doing. So I don't have a specific answer for you, except that we need to look at non-medical models, but they need to have controls so that it is not something that's flooding the streets, as the term was used earlier, and it's not just giving out free drugs to people. It's about engaging with people. And I think that's something that we haven't talked about so much today, but we know that these programs, that when you are in a place where you feel safe and you're able to talk about your drug use, that is a connection that helps people stabilize their lives. It helps people go back where they trust somebody. And we saw this most potently with the overdose prevention sites that really arose organically, but we supported those. And they're places where people felt respected, where for the first time they were able to talk to somebody and were treated like a human being that they are. And they have become so important in supporting people in many communities. We know the work that peers are doing has become so important And they are people that we're working with to find out what they've learned and how we can make things better so that people are able to access the care they need when they need it.
Kier, do you have a follow-up?
Yeah, I do. Would you say, like, throughout this exercise of using limited safe supply in the province, was there a point in time where health authorities kind of realized, like, it might be really difficult or near to impossible to scale up this current model, and we have to start looking elsewhere? And also, how does that translate to youth who are trying to access harm reduction supplies?
Yeah, really good questions. Yes, I think health authorities and my addiction medicine colleagues knew very early on that obviously we put everything we could into it during the early phase of the pandemic, where people were being isolated, where they didn't have access, where the access to street drugs was interrupted in different ways, that we really needed to have something to support people. As things evolved over the last 3 years, there was changes, many different changes, but it became very apparent quite early on that scaling up was going to be a challenge, even in those areas where we have a lot of services for people. It was a challenge for people to find somebody who would talk to them about their drug use, find somebody who was willing to prescribe, get into a clinic, and it became even more challenging in many remote and rural areas. And we tried different ways, whether it was virtual doctor visits and other community supports for people. So this has been evolving. There's no one point in time where we said, oh, we need to stop. It's all been, okay, let's try this in this area. How are you working here? It has been quite divisive for some of our, some addictions medicine specialists, particularly the hydromorphone prescribing. And that's something that we've been working through as colleagues. And it's been very challenging during this, especially in the last year, as things have been changing so dramatically. So there's no one time period. This is something we've been having ongoing discussions of, and it really is going to look differently in different communities. And I'm seeing that now, that there are different challenges in different communities, and depending on who you are and where you live, and whether you're working or not working, or living at home or living in a communal setting, there's very different needs. And so how do we tailor things? How do we work with communities to understand what the needs are in different communities? So these are all things that are underway now.
That concludes today's media availability. Thank you for joining us.
Thank you very much.